Level 1, the Pre-Med Delusion. Age 19, Ohio State University. Biology 201, 8 in the morning, fluorescent lights. A professor named Dr. Kessler, who writes on the board without turning around and speaks as though the class is a minor inconvenience to his research career. You are pre-med, you have decided this recently, with the confidence of someone who has never been seriously tested. You put it in your Instagram bio. You shadow a surgeon named Dr. Patricia Nguyen for 8 hours on a Saturday, and watch her remove a gallbladder laparoscopically in 47 minutes, while simultaneously quizzing a medical student about the triangle of Callow. You understand nothing about what you are watching. You are absolutely certain this is what you want to do. Organic chemistry is the first thing that pushes back. The national dropout rate hovers around 30%. Dr. Kessler seems to experience this as a quality control mechanism rather than a tragedy. Your GPA needs to stay above 3.7 to be competitive. You study until midnight on Tuesdays and Thursdays in the science library on the south end of campus. You volunteer at Ohio Health Riverside Methodist Hospital 12 hours a month, mostly handing blankets to people and trying not to stare at 4 lines. You are building a resume. You are also, without knowing it, beginning to build a self. The MCAT looms. 511 out of 528 is the average score for accepted applicants. You take a practice test and score 492. You register for a prep course. You spend a summer doing nothing else. In August, you sit in a testing center in Columbus for 7.5 hours, and when you walk out into the parking lot, the afternoon light feels like a personal affront. You scored 513. You allow yourself one evening of relief and then begin your application. The applications cost between $2,000 and $5,000 total when you add up the primary AMCAS submission, the secondary applications to every school, and the flights to interviews. Your parents help. You do not take this for granted. In March of your senior year, an email arrives. University of Michigan Medical School. You have been accepted. The national acceptance rate is roughly 42% of applicants, which sounds generous until you remember that only the most curated, most relentless people even apply. You are one of them now. Level 2, Medical School, Years 1 and 2, Ann Arbor, Michigan. You are 22 years old. Tuition is $62,000 per year. You do not think about this number directly. You think about it the way you think about the distance to the nearest star. Technically real, emotionally unprocessable. You sit in a lecture hall at 7:45 in the morning and learn the name of every bone in the human hand. There are 27. You will know them by Thursday. You will also know the blood supply, the nerve innervation, the embryological origin, and the pathology that can affect each one. Anatomy lab begins in October. Your group is assigned a cadaver. You name him Gerald. You spend 6 weeks with Gerald. You learn to separate muscle from fascia with your fingers, to follow a nerve through layers of tissue, to understand the body not as a diagram but as a 3-dimensional argument. The smell of formaldehyde settles into your clothes and your hair. You stop noticing it sometime in week 3, which itself tells you something about what you are becoming. USMLE Step One is the exam at the end of second year. 9 hours, 280 questions. Biochemistry, pharmacology, pathology, microbiology, anatomy, physiology, all of it compressed into a single day that will influence where you match for residency. You study for 3 months using first aid, pathoma, and sketchy micro. You study 16 hours a day. You pass. In 2022, the exam shifted to pass-fail scoring, which sounds merciful until you understand that pass still requires the kind of preparation that hollows you out. You join the surgery interest group. You attend a panel. A 5th-year resident named Marcus Chen says, completely without drama, that he has not slept more than 6 hours in 3 days and honestly feels fine. You make eye contact with the person sitting next to you. Neither of you says anything. Level 3, Medical School, Clinical Years. 3rd year. Someone hands you a short white coat, which is the universal symbol of knowing just enough to be dangerous, and sends you to the surgical floor at 5:30 in the morning. You are on your surgery clerkship. You pre-round on patients before the residents arrive, which means you wake up at 4:15 to review labs and vitals so that when the resident asks you what Mr. Kowalski's creatinine was this morning, you have an answer that does not embarrass everyone present. Your first real operating room. The scrub technician, a woman named Diane who has processed 400 medical students through this room, tells you exactly once where to stand and exactly once not to touch anything blue. You almost touch something blue. You hold a metal retractor for 90 minutes without moving while an attending named Dr. James Okafor performs a laparotomy and, without looking up, asks you to name the layers of the abdominal wall. There are 9. You name 7. He nods. This is considered a success. Match day is March 15th. Every fourth-year medical student in the country opens an envelope at the same moment. You are in a ballroom at the Michigan Union with your classmates. You open yours. Northwestern Memorial Hospital, Chicago, general surgery, 5 years. You cry in a way that is not entirely happiness and not entirely fear, and is mostly both of those things at once, inseparable, which is how most important things feel from this point forward. Level 4, intern year, 26 years old, Northwestern Memorial Hospital. You have an MD. You have a license. You have taken an oath. Your job is to write the notes, place the orders, and answer the pages. You will be paged at 2:17 in the morning because a patient's potassium is 3.3. You will correct it. You will return to the call room. You will be paged again at 2:54. Your salary is $61,000 per year. The ACGME caps your hours at 80 per week. Divided across those hours, your effective wage is roughly $15 before taxes, on top of approximately $300,000 in debt accumulating interest at a rate of $17,000 per year. You have stopped doing the math. The math is not the point. The point is that by month 4 you are placing central lines, large 4 catheters inserted into the jugular or subclavian vein, and the first time you do it correctly without assistance, your hands are completely steady. You had not expected that. A 63-year-old man named Robert arrives with a ruptured abdominal aortic aneurysm. The team moves with a coordinated speed that looks almost choreographed. He dies anyway. You write the note. You call the family. You go back to the floor. There is no debrief. There is the next patient. Your senior resident, Dr. Aisha Patel, communicates primarily in raised eyebrows, and occasionally, when you do something right, a single nod that you will spend the rest of the shift replaying. Intern year does not build confidence so much as it eliminates alternatives to it. You have to function, so you function, and underneath the functioning, quiet and persistent, is the first real sense that your hands belong in an operating room. Level 5, Mid-Residency, PGY3, 28 years old, 2 years in. You walk into a trauma bay differently now. You look at a CT scan of the abdomen and see not an image but a story about what is about to go wrong inside someone. The language of surgery has stopped being something you translate and started being something you think in. Dr. Marcus Webb stands behind you with his hands at his sides while you perform your first appendectomy as primary surgeon. Laparoscopic, 3 small incisions, a camera, specialized instruments. An experienced surgeon completes this in 20 to 30 minutes. You take 58 minutes. Dr. Webb does not touch the instruments once. Afterward, he says quietly, "Good control." You will remember those 2 words for the rest of your career. General surgery residents log a minimum case count in the ACGME system. By graduation, the national average is approximately 977 total cases across alimentary tract, abdomen, trauma, vascular, breast, endoscopy, and skin. You are building toward that number every week. You are also narrowing. You are drawn to hepatopancreatic obulary surgery, the liver, the pancreas, the bile ducts, HPB. The Whipple procedure, formerly a pancreatic duodenectomy, takes 4 to 8 hours, involves removing the head of the pancreas, a portion of the small intestine, the gallbladder, and part of the bile duct, and carries a complication rate of around 40% even at the best centers in the world. This is the operation you want to learn. Then your first real complication. A patient you operated on for a bowel resection develops an anastomotic leak. The connection you made between 2 segments of bowel breaks down. Intestinal contents enter the abdominal cavity. The incidence is 2 to 4%. That number means nothing when it is your patient, your anastomosis, and you are standing at the front of the Morbidity and Mortality Conference presenting what happened in front of your entire department. You present it clearly. You do not minimize. You describe exactly what you did, exactly what happened, and exactly what you would do differently. This is the moment when surgery stops being a career and becomes a conscience. Level 6, Fellowship, 31 years old, Memorial Sloan Kettering Cancer Center, Upper East Side of Manhattan. HPB Surgery Fellowship, one of approximately 15 programs in the country operating at this volume. Your salary is $68,000 a year. A 1-bedroom apartment in this city costs $3,500 a month. You do not think about this, you think about the liver. MSK performs approximately 18,000 cancer surgeries per year across all specialties. The HPB service operates on cancers of the liver, pancreas, gallbladder, and bile ducts, some of the most lethal diagnoses in medicine. Your primary attending is Dr. William Jernigan. When he operates, there is a quality of attention in the room that compresses the air. You have not encountered this before. You learn to be still inside it. A liver resection requires understanding of segmental anatomy described by the French surgeon Claude Quinault in 1957, still the global standard. The liver has 8 segments, Removing 4 of them while preserving adequate blood inflow, outflow, and bile drainage requires spatial reasoning that takes years to inhabit. You are inhabiting it now, slowly, case by case, the way a language becomes fluent not through grammar but through accumulated use. You publish your first paper as first author, a retrospective study of 92 patients who underwent distal pancreatectomy with splenectomy for pancreatic adenocarcinoma. The Journal of Gastrointestinal Surgery accepts it after 2 rounds of revision. You have a single glass of wine and return to the hospital. A patient named Gloria, 61, a retired school teacher from Queens, sits across from you in the clinic. You tell her that her pancreatic cancer is resectable. Her husband grips her hand. He asks you if she is going to be okay. You explain prognosis honestly. 5-year survival for resected pancreatic cancer is approximately 20 to 30%. She looks at you and says she trusts you. This is the most serious thing anyone has ever said to you. You carry it into the operating room the following Tuesday and you do not put it down. Level 7, early attending, 33 years old, University of Pittsburgh Medical Center, assistant professor of surgery, your own patients, your own operating room, your own decisions made without a safety net in real time with real consequences. The first time you stand at the head of a Whipple as the attending of record, the person whose name is on the case, whose judgment is final, the scrub tech looks at you and asks if you are ready. You say yes. You mean it. Your salary is $340,000 a year. After 8 years of post-college training, after compounding loan interest, after a decade of delayed everything, the salary feels both enormous and entirely beside the point. You pay down debt. You buy a used car. You work 60 hours a week because that is what the job requires and because you cannot imagine doing anything else. You build a clinical practice. You take difficult referrals, the cases other centers have turned down, the tumors deemed unresectable, the patients told to go home and get their affairs in order. Some of them you cannot help. You learn to say that clearly and without cruelty. Some of them you can help in ways that redefine what resectable means. You publish these outcomes. Other surgeons read them. A few of them change their practice. You make your first serious intraoperative error. You are 3 hours into a right hepatectomy and you clip a vessel 1 millimeter from where you intended. Bleeding begins. You control it. You complete the case. The patient does well. No one outside the room knows what happened. You write it in your own private log, which you have kept since fellowship, because the only surgeon who learns from a near miss is the one who admits it happened. You begin teaching. Medical students rotate through your service. A third-year student named Priya stands in your OR on a Tuesday morning and holds a retractor for 90 minutes without complaint, and when you ask her to name the hepatic veins, she names all 3 without hesitation. You tell her good. You mean it the way Dr. Webb meant it when he said it to you. Level 8, Mastery, 44 years old, Chief of Hepatopancreatic Obligatory Surgery, University of Pittsburgh Medical Center. You have performed over 2,000 major hepatic and pancreatic operations. You have trained 11 fellows who now run their own programs in cities across the country. You have published 137 peer-reviewed papers. You have sat on the board of the America's Hepatopancreatobiliary Association. None of these numbers are the thing itself. The thing itself is this. You can walk into an operating room and within the first 60 seconds of opening the abdomen, from the texture of the tissue and the behavior of the planes, you understand what the case is going to require. This is not intuition. It is pattern recognition built from 10,000 hours of focused attention to things most people never see. You cannot explain it to a first-year resident. You can only show them, repeatedly, until the day it stops being something they observe and starts being something they know. You operate 3 days a week. You spend 1 day in clinic. You spend 1 day in research and teaching. On Wednesday afternoons, you run the Morbidity and Mortality Conference, and you model what it looks like to present your own complications without defensiveness and without performance, because you learned in your 30s that the culture of a surgical department is built or destroyed in that room. A patient named Dennis, 57, a high school football coach from Altoona, Pennsylvania, comes to you with a tumor wrapped around the portal vein, the major vessel delivering blood to the liver from the gut. 3 other centers have told him the tumor is unresectable. You review the imaging for 40 minutes, you call your vascular surgery colleague, you plan a combined resection and vascular reconstruction. The operation takes 7 hours and 40 minutes. Dennis goes home on post-operative day 8. At his 3-month follow-up, he tells you he coached his team's first playoff game. You tell him that is good news. You mean it in a way that has no performance in it whatsoever. You know things now that you could not have imagined at 19 in a lecture hall in Columbus. You know that surgery is not about heroism. It is about discipline so deep it becomes invisible. You know that the best operation is often the one you decide not to do. You know that a patient's trust is not a compliment, it is a weight, and you carry it, and the carrying is the work. You know that every complication you have ever had lives somewhere in your hands and that your hands are better for it, and that this is the most difficult and most honest thing about the profession. On a Thursday morning in October, you are walking to the OR at 6:45 when you pass a first-year medical student in a short white coat standing outside the surgical floor, looking at a printed schedule, trying to figure out where she is supposed to be. She is wearing the expression of someone who has chosen an incredibly hard path without fully understanding that it is hard. You point her toward the resident workroom. She thanks you and walks quickly down the hall. You watch her go. You recognize exactly what she is carrying. She has no idea yet what it will cost her, or what it will make her, or how many years from now she will stand in a room like yours and understand finally that the distance between that hallway and this operating room is not measured in years. It is measured in every patient, every incision, every 3 a.m. page, every complication presented honestly in a fluorescent-lit conference room. Every moment she chose to stay when leaving would have been easier. She is at the beginning of all of it. You were her once. The work continues.
Hey, if you made it to the end of this video, thank you. These stories take a lot of time to put together, so do me a favor and hit the subscribe button and leave a like. It means a lot. See you in the next one. Bye.